I'm Greg Rosston, Deputy Director of the Stanford Institute for Economic Policy Research, and I'm here today with Jay Bhattacharya, who's an Associate Professor of Medicine and, by courtesy of economics, he's also a Senior Fellow at SIEPR. And we're here on March 31st, 2014, the deadline for signing up for insurance under the Affordable Care Act. And I wanted to ask Jay a few questions about that. So when the Affordable Care Act was being debated, I always thought there were two big problems it was trying to solve, coverage and cost. And there were a large number of people without coverage, and costs were increasing at a rapid rate. Let's first talk about the coverage problem. How have we done?
Sure. It actually remains to be seen exactly how well we've done. I think the data are going to come in. So to give you some idea of the scope of it, somewhere between 45 million and maybe say 55 million or 60 million people in the U.S. before 2014 were uninsured. Right? It lacked insurance coverage, at least for some part of the year. The ACA is aimed at the estimates. The best case estimates of the ACA before the law was passed and sort of for years afterwards has been that they would cover about 15 million of those people. So that there would still be 30 million people still uninsured after the ACA is fully implemented. So but still that's a substantial number of people that it's supposed to cover. And frankly, if the law doesn't result in lots more people being covered, then it would legitimately be deemed a failure. Now, I think that's not a huge risk. And maybe in the short run, there have been some ups and downs, but I think in the medium term, we're going to see a expansion in coverage along the lines I think that people initially thought. There's I should say a couple of things about the structure of the law. There's two ways that it expands coverage. One is by expanding Medicaid, which is the health insurance program that covers the poor. And previously, in order to get Medicaid, you had to have certain special circumstances, like you had to have you had to be on welfare or something. Now, as long as your income is low enough, you automatically qualify for Medicaid, even if you're single, for instance.
And that was part of some states that's true, and other states have.
Right. So 26 states have said no to that, but 24 states have said yes. I think it's actually it's very tempting for states to say yes for reasons we can talk about maybe
that's
in a bit.
That's because the federal government pays all the costs.
That's right? Basically the main reason. Yeah, the federal government pays in the long run will pay about 90% of the cost of new people.
Okay.
So there's that, and then there's the other way that it expands coverage is by establishing these healthcare marketplaces called exchanges, and providing subsidies for people who qualify based on their income for insurance bought through those exchanges. And so through those two mechanisms, it's supposed to increase coverage. The coverage numbers that you'll be seeing on the news now are very, very preliminary. So for instance, it's hard to know whether someone who signs up through the marketplace, whether they had insurance through some other source, like their employer. Now that would, if you shift your source of coverage, that's not the same as covering someone who's previously uninsured. So you got to be careful about counting like that. And I think it's going to be a while before we actually end up seeing how big an effect on coverage it's going to be. But it's likely to have a pretty substantial and positive effect. Many, many people who were previously uninsured will end up being insured.
So one of the questions also, I think, is how sticky it is. People may sign up, but do they keep paying their premiums and that sort of thing to keep coverage up? Isn't that a problem as well?
Yeah, well, especially so we can talk about this a little bit, but like there are parts of the law that require people who wouldn't otherwise want to sign up. It requires them to sign up, and not only that, but to pay premiums that are higher than are justified by their health expenditures. The law, the way it works, is that it has a formula for how much you can charge based on how old you are. And essentially, older people get a better deal on the exchange insurance than the younger people.
So you just hope someday you'll be able to take advantage of that and get old.
That's but in the meantime, you have to keep paying the higher premiums. That's going to be a real challenge for the law, is to keep young people who don't really, at least in the short term, don't benefit as much as they pay to stay signed up.
Okay. So the other piece of the Affordable Care Act goals was to cut down on cost increases. Healthcare has been being a much bigger share of our GDP and our government spending. How has and from what I understand, healthcare costs have come down in the last few years. How much has the ACA contributed to that, or do you expect that it will contribute to reining in healthcare costs?
It's been a controversial thing whether the role that the ACA has played. There are several mechanisms that the ACA has to decrease healthcare expenditures. So the first is to promote integration across healthcare providers, these things called accountable care organizations. There have been some large-scale evaluations that the government has done of how effective these ACOs have been in reducing healthcare costs, and frankly, they've been disappointing to this point. Which is not to say they can't reduce costs in the long run. It's just that the way that they've been implemented up to now hasn't. There's very little evidence that's led to declines in healthcare expenditures. As far as like general healthcare market, there's very little else that the ACA has done to suggest that it would decrease costs. The other side of the market is the Medicare, which is the healthcare insurance for the elderly in the U.S. And there, the ACA does a number of things to reduce expenditures. The main thing being there are planned reductions in the rate of payments to doctors, hospitals, and also to Medicare Advantage plans, which are sort of a private alternative to Medicare that the government pays for. If those planned cuts go in, then there will be some cuts to healthcare expenditures. But most of those cuts are not, they're scheduled to go in. I mean, there's this year some, but really it like ramps up. So like in 2018, 2019 is when we see the biggest cuts to Medicare, and in the out years, not so much right now.
And so do you expect those, sort of the things like the doc fix and other things like that, they get rescinded each year? Is that kind of what you expect to happen since these are in the out years?
Yeah, Congress hasn't had a really good record of keeping to its promises about doing those kinds of cuts.
Okay. For people to see benefits, do you think that the people who end up getting insurance under this, are they going to get lower cost health care than they otherwise would?
Depends on who you are. So if you're 55 years old and you go into the exchange plans, and say you're relatively sick, you have diabetes and you have a history of heart disease or something, you'll get a really good price plan because your health expenditures are really high, but the plans cannot price on the basis of really, I told you about the formula about the age, and they can't price based on your pre-existing conditions. And so what that'll mean is the premiums you face will be much lower relative to your healthcare costs. You'll think that that's a really good deal. On the other hand, if you're a 28-year-old person working, completely healthy, you jog and maybe you do maybe you run marathons or something, you're gonna look at the price and say that's way more than I really need to pay for healthcare because you're in part paying for that guy that's 55 years old. So I think whether it reduces your premiums will depend on who you are. If you're healthier, it'll probably increase your premiums. If you're sicker, it'll decrease your premiums on the exchange plans. And
so this is why we had the whole controversy over mandating people buying healthcare was we were going to mandate that 28-year-old buy it and provide subsidies.
Right.
Does all the money come from within the system, or is there some money that needs to be added to pay for the cost of all this coverage?
Well, a lot of the incentives, there's both negative incentives and positive incentives for someone who's relatively healthy to sign on. So the negative incentives for the mandate is if you say you decide not to buy health insurance because you think it's too expensive for you. In that case, you will have to pay a penalty, which this year is about $95. In the long run, it'll be about $700 for the whole year. Right. So if you're young and healthy, but you're relatively poor, you have some under 400% of the poverty line, the federal government will pay you some money to actually sign up for health insurance through the exchange. So what that means is that you get this positive benefit, which is pretty substantial in many cases, especially depending on how poor you are, and this relatively small negative, avoid small negative harm if you sign up. So those two things together lead people to sign up. The working against that is the fact that you're pooled together with these older people. And so it's not clear, it'll depend on your particular circumstances for which one will dominate.
So does this mean that we have insurance on a year-to-year basis? Does this mean that next year's costs are going to be higher than this year's cost and provide a big shock to people on what they have to pay?
So I think that's one of the bases for deciding whether the exchanges have been successful. So if they're unsuccessful, it'll mainly only draw the relatively sick, older population in, and it won't draw the younger, healthier population in. And if that happens, healthcare costs, the premiums will go up and up and up and up. Economists call that an adverse selection spiral. So if we see that happening, if premiums go way up next year, then you'll know that the ACA isn't working the way it's supposed to work. If, on the other hand, it successfully induces lots of young people to come in, that'll keep premiums down, because if you average in, my healthcare costs with some of my students' healthcare costs, it'll be much lower than if you just count my healthcare costs alone.
So are there small changes that you think you could make to the ACA that would be relatively painless politically, and do help or not? Or is nothing politically painless here?
I don't think anything's politically painless here. I think there's two, if I'd say two major problems with the ACA, and they're fixing them, neither of them are painless to fix. And we've talked about both of them. So the first is this adverse selection problem. And the reason why this adverse selection problem happens is because of something very, very popular. The law says that there's a part of the law that's called a community rating provision. Community rating provision. And the way community rating works is that no matter what your health status is, we charge you the same premium. You're not allowed to account for health status or race or sex or age, really, except for this formula, into the price. Sounds like a great thing. Well, it's very, very popular. But that's why we get this adverse selection problem. So I think that's problem number one. I mean, I think doing away with essentially the community rating law tries to implement a really reasonable social norm, which is that no matter who you are, you ought to be able to pay roughly the same price for insurance. Right? That seems like a reasonable thing, except it causes this adverse selection. There's other ways to do that redistribution. You could allow the market, for instance, to have different price for insurance, and then have subsidies that are greater for people who turn out to be sick. I mean, that would be another way to do it. Or if they happen to, I think that'd be a much more explicit transfer, which is really the aim of the law anyways, is to transfer money in that way. The problem is that making the transfer explicit is politically unpopular, whereas saying the market should have this one community rating thing is very politically popular. But if you had if you got rid of community rating, then you'd also get rid of the adverse selection problem. The second aspect of it that's, I think, sort of problematic is the penalties to employers are way too low if you really want to keep them in the business of providing insurance for employees.
So if you raise the penalties, then this whole example, the differential of not providing insurance and cutting off would be less attractive to the company.
So for instance, you could link the penalties to the total amount of the premiums that the employer would have to pay. So if you drop coverage, you have to pay the penalty equal to the premiums. No one's ever going to drop coverage then. In fact, lots of firms will say, "Well, I'd rather sign on and give coverage." I mean, so if substantially raising the employer penalties would actually get rid of this bad unintended consequence of the law. But of course, that's politically, I think, completely infeasible. I mean, employer groups are barely tolerating the law, and I think it would be very difficult, if not impossible, to raise penalties to the level that would be necessary to induce employer groups to stay on. And you can see this with how the administration is acting, right? The administration has exempted companies between 50 and 100 employees from the employer penalty. And the reason is there's huge amounts of political pressure for small business to say, look, we're not going to, we shouldn't have to pay this because it's prohibitively expensive for us.
But so no company that offers insurance would have to pay for it. So you kind of have a divide between companies that offer insurance and those that don't.
Yes, that's right. I mean, essentially, a lot of the burden of paying for the law would go to the new employers that end up giving coverage, right?
Yep.
But of course, that was the vision of the law, anyways, right? The law was supposed to expand insurance coverage for workers through their employer, and for people who weren't working, or for otherwise were in part-time work or something like that, they could get insurance through the exchanges or through Medicaid. I mean, if it's really truly universal coverage, everyone has to share in the cost. Was the vision of the law. But the way it's worked out, it's, I think, in the long run, likely to be the case that it's really the federal government that ends up paying.